Welcome back. We're going to look at the role of economics, and we're going to jump in here in part two. We've gone over several concepts in part one, and again, the goal of not only this portion, but of this entire class is to help individuals in this class develop that toolbox that is going to help you become successful if you decide to go and work in the healthcare at the healthcare space or the healthcare market. And doesn't matter whether you're working on the provider side of the house or the payer side of the house, or the provider side of that financial coin or the payer side of the financial coin. I want you to have an understanding, because what you will find once you get out in that marketplace, if you're unfamiliar with it now, is there is a lot of flipping back and forth. I've worked on the provider side at Ohio State when I was in graduate school. I've worked on the health plan side. I'm now doing some consulting on the provider side and the health plan side. So you find individuals in the healthcare space floating back and forth between both the provider side and the health plan side. Sometimes they actually float into the government space and then come back out of the government space into one or the other. So it's just want you to have an understanding and want everybody to have the toolbox built with the concepts and some ideas that will help them be successful no matter which side of that financial coin they decide to work on. So let's continue on. And I don't know whether you printed off a copy of the PowerPoint slide that I provided, but I'm somewhat following that PowerPoint slide and I'm on page, I guess if you're looking at the slide, probably on page 4. And it talks about economists. They utilize special disciplines in economic theory to analyze, drive resource allocations, and customer, provider, and government decisions. Again, talked about it already during this chapter 2 about how that the economists are providing information that aids in the decision-making process. And it doesn't matter whether you're a financial economist, a resource, a welfare, a social economist, you're still following the same type or at least a similar type of scientific method as you try to provide information to senior management teams scattered across the healthcare landscape as they try to optimize some type of a functional relationship within their purview or within their scope of responsibility. And as we've mentioned earlier, economists, deal in scarcity. They deal in choice. They deal in opportunity costs. And scarcity is basically limited resources, and rationing drives choices among competing objectives. And in healthcare, especially on the private sector side, you're looking at who's making the decisions. Again, the United States is a market capitalist economy, and most of the resources are not only owned by the private sector, by maybe individuals and corporations, but they are also, since they own resources, they get to make the allocation decisions. They get to determine how those goods and services are allocated across a specific consuming population. And then we've already talked about opportunity cost, the role of alternatives, and the value of foregone opportunities by selecting a specific alternative or intervention. Remember, we talked about the president or the CEO at Meharry. That individual is trying to determine how to use scarce resources and which services to provide and how they allocate those services to the consuming population. And then we talked about the marginal analysis. We make choices as a consuming population. We make choices at the margin or incremental benefits or costs of an alternative. Self-interest, again, goes back to the optimization. It's either maximizing, revenues, maximizing profits, minimizing costs. Everybody wants to maximize some level of utility, whether it's an individual personal utility or it's a corporation trying to maximize revenues. everybody is maximizing some type of functional relationship based on their self-interest. And it goes back again to Adam Smith's Wealth of Nations. There is a tremendous amount of insight in that one publication. And if you've never read it, it's, I would suggest at least doing the Reader's Digest version of it, if nothing else. And then we talk about, in a free market, that the market reaches equilibrium by prices and Adam Smith's concept of the invisible hand. Everyone and everything has a price, and the desirability of services and assets are going to be based on how scarce those services and assets are perceived to be and how much somebody's willing to pay for them. Again, at the end of the day, I think most economists would agree that decisions on supply and demand are, while there are a lot of supply demand shifters that make those curve shifts in a different direction, price tends to be the ultimate driver of supply demand decisions. And when we're looking at supply and demand, we're talking about prices and output decisions. Consumers and providers reach an equilibrium at a specific price, and rationing may occur. So what happens in many economies, especially many market economies or market capitalistic economies, is there have to be some allocation decisions. In the United States, most of it it's price. It's a free market system, capitalistic system, and price usually allocates, or price usually drives the allocation decisions of goods and services in any sector, any market economy, and then healthcare is no different. Some market economies use a lottery system to allocate scarce assets or scarce outputs of production. Some use a first come, first served basis. Some use rationing. Some to get services, just like in the United States, if you're Medicare or you're a Medicaid individual, maybe you have access to services. It's a different rationing or a different allocation process for you to get your services. What you will find is in most areas, if you think about it, you've got private health insurance, you've got Medicare insurance, you've got TRICARE insurance, or it used to be Champus, now it's called TRICARE. And then down here at the bottom, you got Medicaid. And Medicaid is typically viewed as the payer of last resort. And healthcare providers, at least in the Nashville area, and I know so in the Atlanta area where I live, providers sometimes close their practices to individuals that have a Medicare Advantage plan or individuals that have a Medicaid plan. They don't want to accept those individuals covered under those plans because those plans generate lower per unit revenues than private healthcare insurance. And you can lump TRICARE into that too. So Medicare Advantage, TRICARE, and Medicaid are usually plans that you might find providers closing practices to because of the reimbursement levels for those services that are consumed by those populations. Again, it goes back to providers trying to maximize revenues and trying to maximize profits. Competition forces maximization of societal satisfaction. And it doesn't matter whether you're a consumer, you're a provider, you're an investor, you're a government agency, you're trying to maximize satisfaction, maximize utility, and it does help promote production efficiency. So competition helps promote efficiency, and at least here in the United States, it might not in other countries. And if you think back, and I think we discussed it maybe when we were talking about chapter 1, or maybe it was when we were talking about Arrow's article, you get into the competitive market, and a lot of market economies will function within the framework of a competitive market. I'm not really sure that healthcare does for a few reasons. But if you start going down, if you remember your micro classes and you start going down competitive market and assumption, there's, large number of buyers, a large number of sellers, producers or sellers. it is a homogeneous product or homogeneous goods and services, which I don't know. I could argue either way on that one. I guess in general, it's a homogeneous set of goods and services. I'm not sure that from a quality perspective, it's a homogeneous set of goods and services, but at least from a price perspective, it's a homogeneous set of goods and services, because if you are, and I'm, covered by a Blues plan here in Atlanta, and if I'm going to any provider in their network, there's usually I don't want to say a set price, but prices are somewhat consistent across all of their providers, at least the price the health plan pays to the providers. It says, in a competitive market, it's easy entry and access. I don't buy the fact that it's easy entry into the healthcare market if you want to be a provider. There's a long time frame. You're going to undergraduate school, you're going to medical school, you've got an intern, you've got a residency. There's just and you may have some other years that you specialize in some type of service, kind of following Adam Smith's suggestions, but I'm not sure that it's easy entry. And then lastly, complete information about price, and that is, from a consumer perspective, a misnomer. Most consumers, as we talked about last time, again, remember what we said, consumers, until it becomes a consumer-centric marketplace, consumers only see what they pay out of pocket. They don't know, for the most part, the real price of a doctor's visit. Let's say the health plan is negotiated for a medium-based office visit. They've negotiated, I don't know, $60. You go in and if you've got a 20% copay, if you think about it mathematically, if you got a 20% coinsurance and your bill's $12, well, okay, 20% 12, okay, that's probably $60. If you've got a deductible and you go in and you have to pay it all because you haven't hit your deductible, well, yeah, okay, I can kind of figure out that what it's the cost of the office visit is going to be. But if you have a copay, just like I do, and I'm going in and pay $10 for my copay, it's really difficult. Other than the fact that I've worked in the healthcare space for so many years, I have a pretty good idea what that office visit is going to cost, and I know that my $10 copay is not anywhere close to the value of the price of that office visit. So that's where the kind of the competitive market aspect, to me, starts to break down. And we talk about efficiency and utilizing and allocating resources to promote social welfare. Consumers have limited budgets. Again, unlimited wants, limited resources. We've got limited budgets, limited disposable income. Individuals in the state of Tennessee have somewhat of an advantage because you don't have any state income tax. So with no state income tax, you probably have more disposable income than an individual stay in the state of, especially an individual in the state of New York, that is making the same amount of money or the same salary you are, because state of New York is paying a hefty state income tax, so it just automatically reduces their disposable income. And providers, again, trying to maximize profits. So consumers are butting heads in the system. Consumers are almost the forgotten individuals in this battle over this financial coin, because the main individuals battling that financial coin are providers and health plans. But what about the consumers? What about the individuals trying to seek those healthcare goods and services? And then we're also talking about market failure. And free market fails to promote efficiency or optimal level of output. And sometimes you have a market failure where you're operating inside that production possibilities curve. Either you're not utilizing or fully employing all your factors of production, or you're inefficiently using inefficient technology and inefficient processes to transform inputs into output. And at that point, you're talking about market failure. You also could have a situation where something like a natural monopoly or an oligopoly or some mechanism on the provider side is causing market failure. again, worked in the Buffalo market and in New York, and there were two main hospital systems in that Buffalo market, and they were constantly at each other, providing similar services, but always jockeying on who was going to control the healthcare space in the Buffalo market. So it's kind of an oligopoly situation in the Buffalo market. But I think of places, and when I worked at HealthNet and we were providing healthcare services on the TRICARE side of the house, and we had the state of North Carolina was in that north region that we managed, and you're talking about hospitals for miles around in the state of North Carolina that you would have a city. Maybe there was only one hospital in the county. There may have been one hospital in multiple counties for individuals to utilize. And you found that individuals all over the state of North Carolina, because they were having trouble accessing, healthcare goods and services in their particular area, were driving to Raleigh-Durham, trying to, get hospital services at, North Carolina State or Duke, or, going to Chapel Hill to the university. So, kind of that golden triangle. And that's where everybody, a lot of people were going for healthcare goods and services. So that's where it goes back to, market failure. The market has failed. And because of that, you end up with access issues. We talk about values arise by providing a framework and methodology that facilitates one's ability to make sense out of complex economic and social issues. It's a disciplined approach. It's sound reasoning. It's systematic symptom and framework. We're talking about scarcity, uncertainty with unlimited human desires and human behaviors. Again, economics is a social science, quote, science. The economic framework and the economist approach is you develop a hypothesis, you test it. It's you either reject that hypothesis or you fail to reject it. Again, you never accept the hypothesis. You never accept it as true. You either reject it or you fail to reject it. If the hypothesis is tested enough times and it has not been rejected, then it becomes a theory. And then if a theory is tested enough more times or additional times, and it is not rejected, then it becomes a law. But a hypothesis is not accepted, a theory is not accepted, and a law is not accepted. Even though they've been tested multiple times, there's always the possibility of that one instance where it will be rejected. So that's kind of the economist approach, and that's the approach that a lot of economists use in the healthcare market, just like they do in other market economies. And then we keep going that, economic models assume that and this is a big assumption, that rational decisions are made under scarcity constraints. As they try to develop their models, they use simplifying assumptions. I don't know how many times that you've heard the ceteris paribus. It's Latin for all of the things equal or all of the things unchanged. And economists are notorious for trying to simplify the complex world that they work in, especially healthcare. It's so complex, with simplifying assumptions, trying to simplify models to a level where they can actually utilize the models and actually help them forecast and predict and estimate and try to provide that information that is vastly important to the senior management decision makers, whether you're on the provider side or you're on the payer side. Microeconomists assume rational behavior for individual decisions and the allocation of scarce resources. And for the most part, I think, individuals do. For the most part, I think corporations do, especially for-profit corporations, because they are staring down and they don't want to incur the wrath of their individual investors. They're driven by earnings per share. And so they are trying to make rational judgments or trying to exhibit rational behavior. But in the back of those CEOs or those presidents' mind is always, what's that profit margin going to be? And am I going to hit my earnings per share? We're going to stop there on kind of segment 2 of of this chapter 2 in the book. And I'll be back in a few minutes and we'll wind this up with segment 3. See everybody in a few. Thank you.